Hello to everyone. My name is Miro. I'm coming from the country which is with the population, let's say, approximately third of the New York City. But however, we are the first country which started the National Lung Cancer Screening Program. But at the beginning, allow me to express sincere gratitude to Claudia, David, and the whole I-ELCAP team, because a lot of your knowledge, expertise, and data were taken and involved in Croatian National Lung Cancer Screening Program. Today, I will very briefly summarize and show to you the whole design, which is, let's say, unique, the data, not only the data regarding the lung cancer screening, but also data on the some topics of comprehensive screening, and finally, some future developments of Croatian program. The whole program was organized and started 5 years ago. At this moment is running in 20 cities to cover the whole country with three main aims. Of course, to reduce mortality in next 10 years, to increase cure rate, to enroll at least 50% of eligible high-risk population, and finally, to improve and develop different early therapeutic approach in different senses, not only regarding the lung cancer. The whole idea was to build the program which will be self-sustained with enough flexibility and capability to overcome different challenges. But at the same time, the program which will be fully incorporated in the national healthcare system. To achieve that full integration, the special digital platform, unique one, was built. That platform connects all GPs, more than 2,000 of them, 20 or at this moment almost 30 radiology centers, and finally centers for final diagnostic approach and surgery. When we are talking about the analysis of the scans, everything is based on I-ELCAP guidelines, as well as the volumetric analysis guided by AI. Few words about the data and what we done until now. At this moment, more than 50,000 of participants were enrolled. More than 70,000 scans were collected. Just a few numbers to remember. The percentage of positive findings is the same from the beginning, 4.5%. But on the top of that, 10% of semi-positive findings. That is important to know because that will represent the workload for further diagnostic procedures, not only for the screening and the CT. After the previous session, there is no sense to talk about the radiation burden, but in some centers, we are moving from low dose to ultra low dose CT scans without losing sensitivity. And what is the final consequence? You know better than me, then the main goal of the screening program is to achieve stage shift. We expected that, but we didn't expect that we will achieve increase in stage 4 3 times in only first 4 years, despite the fact that we all had COVID lockdown for the 2 years. For us, that is the most convincing evidence that the whole organization is really flexible and self-sustained. That was our idea at the beginning. Go back to the data. In general, 2% of participants were found and confirmed that they have a cancer. Almost 60% of those cancers were eligible and finally underwent thoracic surgery. But I will stay focused on two numbers and two facts from this slide. The first one, more than 70% of the cancers were diagnosed on the baseline scan. And the second, when we are dealing with the huge number of scans, For a small country, that means at this moment, more than 25,000 new scans per year. You have to think about the workload, and some of the centers are overwhelmed with the participants, with the patients. The way how we want to resolve that at this moment is a few scientific projects in the field of different AI solutions in terms to perform better risk stratification, prediction, and probably, I believe, personal tailoring of follow-up scans. Otherwise, that will be not possible to perform so huge number of the scans on the yearly basis. One of the ways, one of the AI programs which are trying to validate at this moment is well-known SIBL program from Mass General. SIBL was applied on more than 30,000 Croatian patients. If you are looking at the preliminary data, it looks very promising. But of course, prospective validation is something which we have to do. And the second most teasing and probably most important part of the screening is the question of comprehensive screening. David and Claudia organized the whole meeting, and we all have to talk about that. Croatia, from the beginning, made decision that all scans will be prospectively analyzed for the presence of emphysema and coronary artery calcification. When you're looking at the data, emphysema was found in more than 40% of participants, in half of them moderate or severe. Coronary calcification is even more frequent, were found in more than 60% of participants, in half of them moderate or severe. What is the main question from the clinical point of view at this moment? How to translate this huge incidence into the recommendation? What should be done next? What to do clinically with all those data and all those participants? When we are talking about the calcium score, tomorrow we will talk also among the never smokers. I think it is much easier to make final decision because we have a lot of data from preventive cardiology. We have a lot of data how and to whom perform lipid analysis and what to do after that. Much bigger problem is what to do with those with emphysema. And that was the reason why we started COPD project. I will very briefly summarize what is the main aim and organization of the project. We analyzed 1,000 consecutive participants and at the same day perform lung function test and low-dose CT scan. After that, exclude from the analysis those with previous history of obstructive lung diseases. There is no sense to analyze them. When you're looking at the data, how many of asymptomatic smokers have new diagnosis of the COPD? Almost 30%. It is diagnosis confirmed and based on spirometry. It is huge percentage. For those of you who are familiar with GOLD classification, 2/3 of them are in the classification 2 to 4, which means they should be treated, not only with preventive measures, but with inhalators or whatever. And allow me to briefly summarize. Based on this huge data, I think Croatia had robust data. We are pretty sure that we can say after only 4 to 5 years of the program, that lung cancer screening program and comprehensive screening can be applied and implemented on the national level. There is no need to stay focused only on the few centers or a small action or regional actions. And one message to all of you, we are very happy that based on this, Croatia is some kind of real-life scientific playground for further studies of the screening and further implementation of comprehensive screening activities. Thank you so much.